edition of ACMT's National Journal Club. We are very excited. The team from Albert Einstein in Philadelphia will be joining us today with a great topic, Takotsubo cardiomyopathy. And presenting today will be Dr. James Kruger, Dr. Sarah Weiss, their fellow, and Serge Emile Simpson, the program director. Just rules of engagement to go over them again. If you'd like to be acknowledged and weigh in with a comment or question, you need to use the raise your hand feature. And for those of you out there active in the Twitter sphere, you want to use the hashtag ACMTNJC. But with that, why don't you folks take it away?
All right, can you hear me okay?
Sounds good.
All right, so thanks for joining us. So again, my name is James Kruger. We're going to talk about Takotsubo cardiomyopathy, and we'll kind of give you a little preamble. So this is kind of the enduring octopus trapped inside of a pot, which kind of resembles ultimately what we'll be talking about today. So just a little bit of a background. This has been described for almost 25 years plus. This is a condition which is a reversible heart dysfunction that was associated initially with pheochromocytomas, but never actually used the term Takotsubo. And this was back in 1989 by Iga et al. About a year later, Dr. Saito and his group in Japan discovered this actually was a reversible cardiomyopathy of the left ventricle that they termed Takotsubo, which was the Japanese word for octopus trap. Elsewhere in the world and in the academic world, they were referring to this as apical ballooning or stress cardiomyopathy. Takotsubo then kind of caught on, and then as we talk about this a little bit further, we'll start to see that over the course of the next 10 plus years, that the number of journal entries regarding this have just kind of jumped up in addition. So this is essentially describing left ventricular dysfunction, which is transient and oftentimes will recover within several weeks. So here's a left ventriculogram. The first picture on your far left shows the end diastolic phase, and then the picture in the middle shows the end systolic phase. You can kind of see that there's a hyperkinesis of the basilar aspect of the heart with essentially non-functioning apical portion. The picture on the far right shows actual Takotsubo from Japan, which they use essentially, like I said, to catch octopus. So we'll kind of pause at the first question. Has anybody actually seen a case of Takotsubo cardiomyopathy?
So everyone jump in there with the audience response, and we'll tally up the answers there.
Okay, should we keep going?
Okay, and Sandra, what did we get on that poll? We had 9 out of 13. 9 out of 13 said yes, so that's pretty interesting. And yeah, that's very interesting. And then, okay, so question number 2 here. Do you think that Takotsubo cardiomyopathy is a poorly recognized problem in medical toxicology? All right, and it looks like we have, how many yes? We have 8 out of 14 say yes, 2 out of 14 say no, with 4 not answering.
Better than nothing. All right. So the first article we'll talk about, or that I'll talk about, is kind of just giving a background of what Takotsubo cardiomyopathy is. It sounds like the majority of people have at least heard of it. We'll talk about just some brief overviews. This is a journal article from Circulation in 2008 by Akashi et al., and this was based out of Japan. So this was a retrospective article that essentially looked at a bunch of different articles as well as postulated a possible rat model for the causes of Takotsubo. So again, it was a review of the recent literature at the time and discussed an animal model that might describe the pathogenesis of the disease process. And so what they did was essentially scan Medline and Scopus for a bunch of different terms that ultimately described Takotsubo within 1989 to 2007. And ultimately they found 10 different studies totaling about 270 patients. 6 of them were actually prospective. Most of them were for either the United States or Japan, with Germany having a single study. And they found that most of the patients that they were describing were elderly women. And most of these patients ultimately had some sort of stressful event just prior, either being physical or emotional stress that provoked what they believe is this series of events. And so ultimately they set up a bunch of questions that they attempted to answer. So this is a breakdown of the characteristics, and I highlighted a few of the different, the important factors, I think, at least describing some big demographic questions. So as you can see, the vast majority of these are women. In most of the studies, in some cases as much as 100%. The lowest, it looks like, is down around 80%. Most of these women were elderly, and that kind of has an important factor, and we'll talk about that a little bit towards the end of my paper. Most of these patients had some degree of ST elevation. When they did look at cardiac enzymes, over half of them were elevated. And then when they did coronary angiography, they also noted that most of these people had completely normal coronary arteries. And so I thought that was sort of interesting because you're describing an elderly population of females who looks, for all intents and purposes, that they had a heart attack, but when they do angio, they actually don't find anything that would show that. And so some of the clinical findings that they also recognized was that in these cases, most of the patients had elevated levels of catecholamines as well as elevated BNP levels. They postulated that this basal hyperkinesis may be related to left ventricular end-diastolic pressures and ultimately releasing of BNP. They also noted that in several of the studies in which they were looking at biopsies, myocardial biopsies, they saw an interesting pattern which started to result, and that's interstitial infiltrates with TMNs as well as macrophages and this myocardial fibrosis with contraction bands. This is in distinct contrast to the the coagulation necrosis, which is normally seen in normal myocardial infarctions. So they're starting to recognize a pattern that is not normally seen in somebody who had a normal heart attack, but something a little bit different, especially in these people with elevated BNPs and catecholamines. So they tried to postulate a couple different theories as to what might be the cause of all these things, and you can kind of read what they were. And what we'll do is we'll kind of go through each one of these and kind of discuss the pros and cons of these, as well as kind of give a little bit more information. So the first one is this multivessel epicardial coronary artery spasm. And so some of the things that they would speak in favor of this is that they saw this reversible dysfunction that might result from epicardial spasm and subsequently stun myocardium. But some of the things that don't agree with this is the fact that the stun myocardium, when I explained the discrepancies between the significant dysfunction and barely elevated cardiac enzymes. So most of the cases they saw that the cardiac enzymes were barely bumped, but they had this marked degree of dysfunction of the left ventricle. Also, another con would be that even if they did have a single plaque rupture, it would only affect potentially a single coronary artery, which wouldn't really describe the massive territory that would be supplied by to the left ventricle. So the fact that you get this almost global dysfunction of the left ventricle doesn't really begin to describe the single territory that might have an actual plaque that ruptured through it. So they also looked at this idea of microvascular impairment. which is an interesting concept because I never really thought about this, maybe because I'm not a cardiologist, but they noticed that this abnormal left ventricular wall motion may be related, they see this in patients with Takotsubo, and they think that this might be an abnormality in this microcirculation, and they found that in a lot of these patients, they had metabolic abnormalities, which they saw in PET scans. However, this is a correlative relationship, what they ultimately figured out. And they said that some of this metabolic abnormalities may be a result of sheer wall motion stress that is caused by this, hyperkinesis of the basal aspect, and then thus causing these microvascular circulation issues. So it doesn't exactly fully explain it. And so when we discuss the next aspect, which is catecholamine toxicity, and so this is kind of where they're putting a lot of their eggs. Catecholamine toxicity is seen and was described by this group, Whitstein et al., and they found that circulating plasma catecholamines were significantly elevated in those with stress cardiomyopathy or Takotsubo who had this apical ballooning. And when they compared that to those patients that were hospitalized for, run-of-the-mill AMIs, they found that the epinephrine and norepinephrine levels were significantly elevated in comparison to the two. They also found that epinephrine seems to have more cardiac effects than the norepinephrine. So some pros of this were that the myocardial histology in Takotsubo resembles that seen in catecholamine cardiotoxicity is seen in things like pheochromocytoma. However, these elevated catecholamines are not uniformly seen in every single one of these patients, and it's also seen in those with pheochromocytoma. So again, kind of getting close to the mark, but potentially not explaining everything. And so lastly, this is kind of the most interesting in my opinion, was the neurogenic stun myocardium. And so what they're seeing are these EKG abnormalities in Takotsubo that reflect activation of the central neurogenic mechanism, which this is analogous to subarachnoid hemorrhage, causing left ventricular dysfunction. And so what they found is that there's a high density of these adenoreceptors at the apex of the left ventricle, and that things like cardiac sympathomectomy in rats and other rodent studies have shown to prevent these brain-mediated cardiac dysfunction. And so they're thinking that there's ultimately something going on with the central nervous system being able to modify and modulate these effects. And so some of these animal studies show that these decreased ionotropic responses to norepinephrine in the study of catecholamine-induced cardiomyopathy, and that the heart depends on this neuronal uptake for inactivating catecholamines in the extracellular fluid, which might explain why the primary site of toxicity is cardiac-induced when you have total body, despite the fact you have total body elevated levels of catecholamines. And so the issue then becomes you have these elevated levels of catecholamines that is causing myocardial stunning, and the fact that you can't inactivate any of these catecholamines may be why we just see isolated cardiotoxicity in the setting of total body elevated catecholamines. And so then lastly, they proposed a mechanism based on a rat study. This is a mouse, so not exactly the same, but still. And so this rat model questions, they asked why in particular are elderly women susceptible to this, and how does this profound psychological stress ultimately trigger this condition? And so what they ended up doing was essentially immobilizing rats. And by doing this, they see massive catechols released that are very similar to Takotsubo cardiomyopathy. They see these EKG changes with ST elevations, they see T-wave inversions, and they see this apical ballooning that is very similar to those in humans. They also found when they immobilize these rats that increased catechols will also increase these cellular excitation genes such as CFOS and CJUN in the endothelial cells and ultimately serve as a, so to speak, marker of dysfunction. And so the EKG changes and early gene expressions, they also noted were prevented by the use of alpha and beta blockers. They also noted that there's a specific correlation with estrogen receptors. And estrogen is kind of diffusely expressed throughout the body, but in the cardiovascular and the central nervous system, they think that this was ultimately putting elderly women at higher risk. They think that when estrogen levels are decreased, they don't have this, I guess, preventative effect of all these different, I guess, effects that would ultimately release a couple different proteins and ultimately tamp down the effects of cardiotoxicity. And so they also showed that neurocatecholamine release and expression of early gene expression was seen to be attenuated by the use of exogenous estrogens. And this also helped to release cardioprotective atrial natriuretic peptide as well as heat shock proteins in the heart. So lastly, with mine, this is a schematic of how they propose all of this working. And so you can see that that ultimately some emotional or physical stress has happened, and this caused a release of a signal through the central nervous system and ultimately causing the adrenal medulla to release both norepinephrine and epinephrine, which affects both beta and alpha receptors. Also, you can see that this reduced estrogen levels after menopause has a bunch of different effects as well, which is essentially downregulating of heat shock protein 70 and ANP, which can also lead to mechanical wall stress, which leads to hypocontraction of the left ventricle apex. This all leads to a series and cascades of events, especially when you talk about the alpha and beta effects with the hyperkinesis of the basilar aspect of the heart, as well as this, you essentially get an outflow obstruction, and this leads to increased mechanical wall stress and hypocontraction of the left ventricle. All of this leads to catecholamine toxicity, which ultimately leads to oxidative stress, and it's a big feed-forward loop signal in which they use to essentially describe the toxicity of Takotsubo cardiomyopathy. So with that in mind, I'm going to turn it over to Dr. Simpson if there's no other comments or questions. I'm sorry, Dr. Weiss.
Yeah, so that was great. And just to give everyone an opportunity, if anyone has any specific questions, just shoot your hand up and we'll be happy to acknowledge you. Yeah, no, really interesting article. I know you may get into it earlier, but like one thing that jumped out of the paper to me was this contraction band, and just made me think about the CARCH bands or contraction bands we've seen from cocaine toxicity and cocaine cardiomyopathy. Have you guys seen anything relating Takotsubo to cocaine toxicity?
There are two papers we didn't include because they were just surveys of drug-induced, Takotsubos, which are, arguably are super germane to this journal club, but there's just not much to sort of comment on. And I added them at the end of the slide set so that the listeners could go and read them on their own. I highly recommend they do that. But they do mention that there are histologic similarities between cocaine and methamphetamine induced Takotsubo, cardiomyopathies and Takotsubos. Yeah, those are at the end of this slide set. You can see the two. There's a keto article and I think an Izumi article.
Yeah, Izumi.
Okay, awesome. That's great. Okay, well, without seeing any hands, why don't we press on?
Well, I just have one thing to add. When I was reading this paper, I was bothered a bit by the estrogen receptor, theory because, in my mind, I'm thinking that a postmenopausal woman can't possibly have less estrogen in her system than your average male. I could be wrong about that, or even an elderly male. I mean, so why are we, not seeing elderly males represented or young males represented in the same way that elderly females are? I feel like there's something more there that needs to be explained.
I think there's more to being an elderly female than just having less estrogen.
Having dead ovaries, yeah.
Fair point.
So my name's Sarah Weiss. I'm the junior fellow here at Einstein. So I'm going to talk a little bit. I came from an EM background, just graduated. So I'm going to talk a little bit about the sort of broader picture in this review that's really probably the largest collection of patients with Takotsubo, because it's just not that common of a condition. I think I was lucky that I saw it once in residency. So there's this registry called the International Takotsubo Registry, which was started in the 90s, and my little graphic lineup didn't work out very well, but it's these 9 countries and 25 different centers that collect data on patients diagnosed formally with Takotsubo using the the diagnostic criteria we have listed, which I got kind of a kick out of some of their results that they found because some of them are like definitional, you know, but the diagnostic criteria here are transient abnormality in the left ventricular wall beyond a single perfusion territory, and then an absence of obstructive coronary artery disease or evidence of plaque rupture. Those sort of together would be the definition. They can also have new EKG abnormalities or increased troponin and no pheo or myocarditis to explain the clinical presentation. Now, they do make exceptions that if you have coronary artery disease pre-existing, but there's no culprit lesion or it doesn't fit with the abnormality in the left ventricular wall motion, then they would still consider that like inconsistent and likely Takotsubo. And then if your abnormality is not transient because you died before you got better, you could still be diagnosed as having Takotsubo. So this was a 10-year analysis, so they sort of aimed for this over 10-year analysis of patients, but it's partially retrospective and partially prospective because they started analyzing data in 2011, but they went back to 1998, and then they continued collecting through 2014. So this huge number of patients, 1,750. Now, I think that's huge for Takotsubo, but keeping in mind that we're looking at, you know, over 10 years and there's only 1,700 patients, sort of highlights that this isn't that common. And then they followed up as much as they possibly could on these patients. Only 1,282 had 30-day follow-up information. We're going to see soon with the 10-year outcomes, how they kind of like people dropped off and lost the follow-up, but they were able to analyze about 1,000 for how they survived, depending on what they were prescribed at the time of discharge when they were diagnosed with Takotsubo. And then they did this cool matching where they took 455 patients and then age and sex matched them with patients with ACS as a comparison. Also, I think Octopi are awesome, so you're going to see a lot of little memes on the bottom here. So getting started, I think consistent with James' paper, we saw mostly females, mostly elderly females. 80% were women over the age of 50, commonly presenting with chest pain, dyspnea, or occasionally syncopate. Very few had this like kind of incidental finding. You can see those numbers don't add up to 100 because some people have chest pain and dyspnea or chest pain and syncopate. But the numbers of males kind of is really paled in comparison to the numbers of females, and it drops off pretty quickly in this younger range. Now, once you look at a lot of patients, I think you find some changes in the pre-existing sort of ideas about this, like quote unquote broken heart syndrome, the idea that these, you know, elderly women have some kind of stressful event and that's what causes it. A third of patients had no apparent trigger, the most common was a physical trigger, not an emotional one. So I highlighted here an emotional and physical stress. And then this is from the supplement. I don't know why it's doing that. So this is from the supplemental, the supplement to the article where I found there was a lot of good information. I was like, well, what's a physical trigger? Like, what were they counting as that? So like acute respiratory failure, having a surgery, neurologic conditions being pretty common, infections. I guess they lumped just a whole bunch of others. And then in terms of emotional triggers, you've got things like grief, panic, interpersonal conflict. Certainly these are largely stressors that I think could cause that sort of catecholamine milieu that we're looking at. All of this could. Okay. So this is kind of summarizing the meat of their baseline characteristics. This graph was not in the article. I made it because I wanted to have a better way for us to really see this. So I put the little asterisks down here for the ones that were statistically significant, and then there's 2 down here that I included. The 2 asterisks is that it was kind of like almost statistically significant. By my consideration, it was pretty dang close. So what I found interesting is, as coming from out of residency, like, okay, your troponin really isn't helping out here. They're basically the same. Some other things that, were not significantly different were like cardiogenic shock, risk of death, with Takotsubo on the left here and ACS on the right. I always learned that Takotsubo was transient and benign, but anything that's showing me here is that it's really not, and these patients are as sick or possibly even in rare cases sicker. So, some things are pretty clear, like your ST elevation, a little more common, reciprocal ST depression, certainly more common in ACS, but your BNP is more likely to be elevated in Takotsubo. Your ejection fraction is likely to be lower. Your chance of on admission having a neuro or psychiatric disorder is almost double. And then in terms of, and this is the acute neurologic disorder here, just how different that is. And then the treatments over here and the outcomes, the positive pressure ventilation, the fact that a lot of these patients did end up needing either non-invasive or invasive positive pressure ventilation, I think highlights how sick they can be with this acute heart failure syndrome. I didn't really learn about it as an acute, potentially decompensated heart failure, but there it is. Oh, and sorry, down here, a third of them were already on a beta blocker, and a third of them were already on an ACE inhibitor or angiotensin receptor blocker. So again, from the supplement, I wanted to highlight some of these, like what neurologic disorders, like what do they mean by a neurologic disorder? And again, they're comparing between ACS and Takotsubo. But just looking at, like, okay, we're talking seizures, intracranial hemorrhage, strokes, TIAs, headache disorders, and whether they've had it in the past here or whether they have it acutely. And there are some other studies that highlight that in the intracranial hemorrhage and stroke population, you can have this sort of sudden unexplained heart failure. And there was an interesting one showing that patients with sudden unexplained cardiac death following an intracranial hemorrhage or seizure, histologically their hearts look a lot like Takotsubo. And then here's some of the psychiatric disorders that they're talking about, whether they're acute or former or chronic, so pretty high prevalence there. And I wondered when looking at this if maybe there was some selection bias, because I don't know what the rates are of these conditions in, say, the just general elderly female population, but certainly there's a difference between Takotsubo and ACS. Yes, age matched. So this is, again, highlighting for me, and one of the big things I took out of my paper is that these patients can be just as sick as acute coronary syndromes. This is, again, from the supplement, the composite endpoint that they're looking at, which is all of these things, which is did they require catecholamine support. Unfortunately, this is post-diagnosis, not pre-diagnosis. Like, did they have a catecholamine, some kind of exposure, like were they in septic shock and on a pressor, like norepinephrine and epinephrine that might have induced it? We don't have that information, and I think that would be something really interesting to find out. Rates of cardiogenic shock may be trending a little towards high, but not significant. And then this sort of requiring all of these sort of high-end invasive interventions. So predictors of having this bad outcome would be this young age, having a physical trigger instead of an emotional trigger, having that existing acute neurologic or psychologic disease as opposed to chronic or none, having a severely elevated troponin or a severely depressed ejection fraction. So it's kind of one of those, if you are young and you get this, it's a bad sign. If you are not having an acute emotional issue per se, like a trigger, but you're having a physical one, like you have an infection or something of that nature, then you do worse. And men also did tend to do worse with this condition than females. So this is your long-term outcome, sort of tracking along who we were able to follow up, not we, but, you know, who the authors were able to follow up to 30 days and seeing that, you know, you do have this rising percentage of acute cardiac events, death, and then recurrence is down here. But this risk of stroke was very different between the Takotsubo patients and the ACS patients. That Takotsubo places you at a significantly elevated risk of stroke or TIA in the immediate post-illness period. And then here they were able to follow out a fair number of these patients who were discharged on an ACE inhibitor or angiotensin receptor blocker versus a beta blocker. And this is the part that I think throws us off. And this is the wrench in the gears here, that we have the patients discharged on an ACE inhibitor. So these are the ones who didn't get an ACE inhibitor here. And this is your death percent going up the side. And then here's with the ACE inhibitor. So that's looking pretty good, and it reaches statistical significance. So I would call this statistically and clinically significant. On the other hand, here's your patients who were discharged with a beta blocker on the top line and the ones without a beta blocker on the bottom. And there's no statistical significance there, and it's also sort of the wrong way for what we would be hoping for. So to summarize this paper, I think it was good at sort of upholding some things, but only a couple. It's an older female population by and large, an acute heart failure that's transient and asymmetrical unless you die while it's still going on. But it busted a lot of myths for me, that this is not really a broken heart syndrome, but more of a physical trigger or no apparent trigger at all, that it's associated more with neurologic disorders like subarachnoid hemorrhage, seizures. This is the ECT therapies, the electrical stimulation therapies can cause it as well, stroke, and then EKGs and troponins not really helping you to distinguish these things, and that it's not mutually exclusive with pre-existing non-obstructive coronary artery disease, because 15% of patients did have that. But the most important myth that busted for me is that this is not benign, has similar negative outcomes to acute coronary syndromes, and that there was no benefit from a beta blocker in this one. So what does that have to do with the catecholamine theory that we've established? Here comes Dave. He's a hugger. You want to talk about this one?
All right. Steve, did you want to?
Yeah, you know, again, I'm not seeing any hands if anyone wanted to weigh in, but maybe at the end. But no, that's a great paper, great job. Why don't we keep pressing on?
Okay. Well, I'm Serge Simpson. This is an article that I chose because I'm always looking for decent animal model articles to sort of help ground my understanding of some of the physiological principles that you don't often get from the human research. This is kind of what I chose to look at. Effects of metoprolol on epinephrine-induced Takotsubo-like left ventricular dysfunction in non-human primates. This article was in the Hypertension Research Journal in 2009. Yasukatsu, Izumi, et al. Some of these names are familiar from other papers in the reference sections of the previous two articles. So it's, sort of well-known researcher in this area. So the background of this article, this is, the articles reference their own work, earlier work that had shown that using these macaque monkeys, they could, generate a good model for possibly Takotsubo's cardiomyopathy. I guess these monkeys are the right size, that they could basically get an echocardiogram probe on them, and then they could accurately measure left ventricular shape, volume, and function in this animal model. They'd shown that in a prior paper. And then they also showed in a prior paper that excessive epinephrine infusion caused temporary left ventricular dysfunction that kind of looked like the Takotsubo's cardiomyopathy that they'd been previously described in human patients. And then their goals for this study in this third sort of round with this real-time 3D echocardiogram model with these monkeys was to basically, look at a larger number of these monkeys, so see how fitting this model would be for investigating Takotsubo-like illness, and then determine if metoprolol had any therapeutic value for this inducible cardiomyopathy. So they started with 25 cynomolgus monkeys, which is I guess the scientific term for these macaques that are found in Asia. So I think that's actually one barrel full of monkeys. I'm not sure. That's just kidding. And then they basically induced left ventricular failure with repetitive epinephrine infusions, and there's the dose that they used. Now they did 2 back-to-back infusions on day 0, essentially. And then their plan was to sort of induce somewhat of a long-acting cardiomyopathy. So 3 days later, the monkeys at least the plan was 3 days later, the monkeys that still had an EF less than 40% would be included in the study as, cardiomyopathy monkeys. And then they would start the experimental phase of their protocol on day 3 after the infusions. I really couldn't find a reason for why they set this up like this. When I picked this article, I was under the impression that this would be sort of an acute model of LV dysfunction under the influence of epinephrine infusion, but it turned out not to be that. It's kind of almost like a subacute cardiomyopathy induced by this epinephrine infusion that occurs 3 days before any sort of treatment is given. And then their plan was to divide the cardiomyopathy monkeys into 2 treatment groups. One would get saline, the other metoprolol infused. Over only 10 minutes, and then they would measure the left ventricular size and function with this 3D echo technique they developed at 10 minutes, 30 minutes, 2 hours, 1 day, 10 days, and 30 days, after the treatment. And the second experiment was the histological group. They would basically treat the 2 groups of monkeys, saline and metoprolol, these small N's here. And then 1 day after the treatment, they would harvest the hearts and then section them, basically prepare the sections in paraffin and then, look for microscopic evidence of inflammation and also do RNA analysis, as well. And then they would compare these to 5 control monkey hearts that received neither epinephrine nor metoprolol, just as basic controls. Unfortunately, or interestingly, I should say, during the day 0 infusions of epinephrine, 9 of their 25 monkeys just died. Pretty spectacularly, it sounds like. They, in the middle of either the first or second infusion, 9 of these monkeys died, and they all had evidence of pulmonary hemorrhage and pulmonary edema. And they have one example here in the paper of the differences between the monkeys that died, A, and the monkeys that survived this sort of epinephrine infusion section on B here. And I guess they're trying to put it up there to sort of see if we can find a difference amongst these, these 2 groups. Certainly they, a third of these monkeys just up and died immediately, which kind of makes me think about, when Dr. Weiss talked about her article, if you weren't going to include the dead patients in your sort of registry of Takotsubo's cardiomyopathy patients, could you be missing, sort of an important subset of these patients that, that die quickly? But here you can see, the ectopy, the authors mentioned that ectopy started almost immediately for the monkeys that died. But, if you look at sort of A line 2, it doesn't look so different to me than, B line 3, where you have these sort of normal sort of sinus beats interspersed with multiple PVCs. There certainly are a lot of similar tracings here before you get down to like A line 5, where like the VTAC starts. and the monkeys die soon thereafter. So I don't know if it's going to be possible, on a monitor to sort of catch these patients who are going to die, early, But I thought this was interesting. I really wish that they expanded more on these monkeys that died and presented more data about, what all of their EKGs look like. But unfortunately, this is all we get. Here is, data from their experimental arm. So, it took me a while to figure out what's going on here. But this is the heart rate response to epinephrine, and then, during the infusion, it goes up and plateaus at a pretty high rate. Systolic and diastolic pressures also go up and plateau at at the rate seen here, which is interesting considering they all have, EF deficits. And then here in line B, this is basically the same data with the second epinephrine infusion. They look similar because essentially similar things happen. And of course, this is from 16 monkeys because 9 are dead. And then here is the ultrasound data showing that, so it starts here on day 0, which is actually day 3, right? So there's day 0 of the treatment, day 3 of the total sort of, ordeal that the monkeys have to go through because the epinephrine infusions occurred 3 days earlier. So of the 16 monkeys that survived to day 0, you can see that the EF in the saline treatment arm group is significantly depressed compared to, I don't know about significantly, but is markedly depressed compared to the metoprolol group early on. And for the first day or so, the EFs remain depressed similarly in both groups, and then they both start to rise after a day as the monkeys enter the recovery phase. Here's experimental arm 2, the histology group. I thought this was a little interesting. They showed here that the difference between the ejection fractions of the control monkeys versus the epi-exposed monkeys. So that kind of proves that their EFs did go down. Like they were normally 65%, and then with the epinephrine infusions, day 3 after the epinephrine infusions, these monkeys still had markedly depressed EFs, both groups. But the metoprolol group a little bit less depressed. But not terribly different. Histology was a little bit different. Like here on the top, you can see that they basically separated the histological sections between basal and apical cells to just, account for, basically to investigate if the different things were happening at the microscopic level in these different parts of the heart that seem to be affected differently by the, by the catecholamine rush. Here, in the control monkeys, there's no evidence of inflammation in either section of the heart. In the epinephrine-only monkeys, there's some leukocyte infiltration, and then in the apical section in particular, there's areas of myocytolysis, basically destruction of the myocardial cells, which is what these arrows are pointing to. And then, in the metoprolol group, the histology is essentially returned almost to the control group's sort of findings, where there's, marked absence of myocytolysis, especially in the apical portion. So something is definitely responding to the metoprolol, at least in the histologic slides shown here. Here are the gene expression studies. There were many of these, and I really don't know enough about the sort of background research, on these specific, genes and how they are correlated with CHF and cardiomyopathy at large. So, and I really apologize for this because this was a dense forest that I kind of wandered into. But these, let me just, I think NTBB is a BMP precursor, and CTGF is I think, thank you, connective tissue growth factor. My presenter notes are being, read to me as I speak here. And OPN is osteoponin, I think, and I really don't know what that is. But you can see that there are some regional variations in expression of these genes under the influence of epinephrine, and then metoprolol seems to affect apical expression primarily of the OPN, group here. I really don't know what to take away from that. Clearly some sort of gene expression in these known CHF markers is being altered by metoprolol. That's all I can tell you. In terms of this other group, the cellular machinery group is what I call it, ryanodine receptor gene, the sarcoendoplasmic reticulum calcium ATPase gene, and also adenylate cyclase 7 genes are represented here. And it looks like ryanodine receptor is depressed by epi exposure, in a differential fashion, apical greater than basal. Metoprolol doesn't seem to affect this. Circa depressed apically and stimulated basally by epi. And metoprolol blunts the rise in the basal tissue. Thank you. And adenylate cyclase stimulated apically more so than basal, and metoprolol has no effect. Moving on, renin-angiotensin genes. These are basically receptor genes that code for the different receptors, 1 and 2. And it looks like there's some sort of mild. There's the epinephrine treatment. Does mess with these gene expression in a differential fashion. Seem to be important for the development of the cardiomyopathy, but metoprolol doesn't make a difference across the board. I got these mitochondrial-related genes. I really did not know what to say about this at all. And by this point, the gene expression for adrenal receptor genes, I was very much regretting my choice of articles. So I apologize. So, what did I learn from this article? That these cynomolgus monkeys apparently made good subjects for, stand-ins for humans, if we're going to study, all cardiotoxic drugs that seem to affect, LV function, because, they're large enough to, I guess, to generate reliable echocardiogram pictures. What I didn't mention here is that the way they, on the prior article, what they did to prove that this was a viable model was they would take measurements of the left ventricles of these monkeys and then harvest the hearts from these same monkeys and then make what they called sausage-like sections and calculate the actual volumes of the heart and then correlated it to the echocardiographic calculations for individual monkeys, and they found the correlation was excellent. So that's pretty interesting technique there. Also this is interesting. Metoprolol seems to confer an early but modest improvement in EF in this model of Takotsubo-like illness. I thought that's fair to say, even if it was only a handful of monkeys, half a barrel or so. And then epinephrine infusion, clearly dangerous, and especially for a subset of these monkeys, and that expired before any treatment could be administered. I really kind of looked at epi in a new way after seeing that data that 9 monkeys just up and died almost immediately. What I wish was different, I really wish that they would have expanded on what happened to these expired monkeys, if they could have shared more data on what they collected, in that short period of time when they were dying during the epi infusions. And I wish they'd unpack that a little bit. And then this, what else did I say here? This model seems to be more interested in exploring metoprolol as a means of speeding LV functional recovery rather than as an actual preventative for Takotsubo's or an acute rescue treatment. Basically the timing was all wrong to see if metoprolol would have any use for those of us in the ER dealing with somebody with an apparent acute LV dysfunction from emotional physical distress. So really was kind of the wrong article to answer the question in my mind. So that's my fault for choosing it. And I wish the authors would have explained in this paper why they chose that model of back-to-back epinephrine infusions. I'm sure that exists somewhere deep in the literature that came before it. Why do you have to expose them twice? I ran across a couple of, references to, these rat models where repetitive, infusions of epinephrine cause sort of a summative LV dysfunction, phenotype, and just, that must have been the reason, but I didn't really get a chance to explore that further in other papers. But they didn't really comment on it either in this paper. And here are the 2 sort of drug-induced Takotsubo surveys that I thought were great reading. I just didn't really think that they were going to be useful for sort of carrying apart in a journal club setting. But I highly recommend people who are interested in this to sort of read these. These are basically big collections of case reports, and then they kind of go through them and weigh the merits of the sort of, basically the strength of evidence for linking, a specific substance to the development of Takotsubo's. And they also both sort of look at 5-FU as a chemotherapeutic agent, which seems to be related, associated with Takatsubos, or at least this sort of contraction band cardiomyopathy, and sort of decide that it's something probably different is going on with 5-FU exposure than traditional Takotsubo. So I highly recommend getting one or both of these. The Keto article is the more recent of the two, but the Izumi article I thought was a little bit better. And that is it. Thank you for your participation. And I give the mic back to Dr. Axe.
All right, Serge, thanks so much. That was awesome. And I think those were 3 fascinating papers. I mean, I know that they've gotten our wheels turning here. We're talking about this. And again, if anyone would like to make a comment or ask a question, please raise your hand. Have you, after looking at these articles, are you guys interested in getting more echoes in the ED in your sympathomimetic overdoses, or any thoughts on where you'll go after diving into this topic?
So for me, it's Sarah here. I think I don't know how many other junior fellows or really fresh out people are in, but reading these articles actually really changed my thought process a lot about this, the sympathomimetic sort of picture and the importance of echocardiography. I'm not good enough to really see something unless it's profound regional wall motion abnormalities. Otherwise, I can measure an EF, and that's pretty much it. But something that I think I do at the bedside sometimes, and I probably need to do more. And the other thing is just I don't know if it's going to change my practice on the use of stressors when they're needed, but it's certainly going to change my thoughts in terms of the possible side effects of that treatment, that this is something that I have to keep in the back of my mind as a risk.
Sure, that makes a lot of sense. Okay. Yeah, one other thing these articles made me think of was Michael Shannon years ago did an interesting paper looking at theophylline toxicity measuring catecholamine concentrations, and just demonstrated that they're not surprisingly extremely high. So you just wonder, do we see this type of effect from, from multiple range of drugs that would cause catecholamine surge? And, it's one of these things that are just below the radar. None of us have thought of it. I don't know the answer to that. Okay. All right, I'm not seeing any hands. Do you guys have any final wrap-up comments?
No, I had a lot of fun. You were right. This is fun.
All right, excellent. Well, that was, thank you. Thanks so much, James, Sarah, and Serge. Those were really wonderful articles, really thought-provoking. And to everyone out there, the next National Journal Club is November 13th. I'm still juggling potential presenters, but if anyone would like to get into the upcoming list, please shoot me an email. And again, thanks so much from the folks at Einstein, and we'll see you next time.
Thank you.
Thank you.
Thanks a lot.